on China and went to the National University in Taiwan for medical school, came to America in 1974, I believe, and went to Cook County where he did his internship and residency, and then went to New England Deaconess where he worked with Bill Crosby, who was one of the really leading eminent hematologists of the 60s and 70s. When Bill Crosby went to UCSD, he took Dr. Yam with him, and Dr. Yam worked there for quite some time and then came to Louisville where he was a professor until he passed 5 years ago. Dr. Yam was truly a outstanding physician. He had a great scientific career, discovering quite a number of important markers, including tartrate-resistant acid phosphatase for hairy cell leukemia, and published more than 190 papers. But he was really known as a great physician and a great teacher. He would spend hours at the microscope with the students and fellows. He was really one of the last great classic hematologists. His patients loved him, and he really was a treasure to this university. Beyond that, though, he was a great human being. He was a great husband, a great father, and a great friend to many of us, and we miss him still. But I'm very, very glad that we can do this lectureship in his honor, and we've had quite a number of really outstanding speakers, and today is no exception. And so I'll introduce Bill C. to introduce the speaker.
Good morning, everyone. Morning. Thanks for coming to today's special grand round. I'm very happy to introduce the distinguished honor speaker of our 2018 year memorial lecture speaker, Dr. Gregor Hoermann, who is a chief senior physician at the University Hospital of Innsbruck, an assistant professor of Department of Laboratory Medicine at the Medical University of Vienna, Austria. Today, Dr. Hoermann is recognized as a rising star in molecular pathology in Austria and EU. Dr. Hoermann is a native Viennese and received his medical degree and Ph.D. thesis work in malignant hematologic diseases from Medical University of Vienna, Austria. He completed his residency training in laboratory medicine and moved up to the head of genetic laboratory at Medical University of Vienna. After that, he went on to do research fellowship at world-renowned MLL Munich Leukemia Laboratory in Germany, where serves as a central reference pathology laboratory for many countries in the world, including the United States. I have known and collaborated with Dr. Hoermann since 2012, when I was a visiting professor and scholar at the Ludwig Boltzmann Institute for Cancer Research, Medical University of Vienna. He was introduced to me by a long-term collaborator when my lab was struggling in gene transfer efficiency through viral transduction. At that time, I was told, Gregor can get whatever gene you want into whatever cell you want it to be in. That's how all these years we have been colleagues and friends since. As a rising star in diagnostic molecular pathologist, there's no better choice of a speaker than Dr. Gregor Hoermann for this prestigious Yam Memorial Lecture to honor Dr. Yam, who discovered the early diagnosis method for hairy cell leukemia. Please join me to welcome Dr. Gregor Hoermann.
Good morning, dear William. Thank you very much. Yes. Do you hear me? It's fun. So good morning, everybody. William, thank you very much for this kind introduction. I'm really happy to be here with you. I'm deeply honored to give this lecture in memoriam of Dr. Yem. So yesterday we talked about Dr. Yem and his passion for morphology. And today I will add another layer of diagnostics to this. Morphology is still the base of what we are doing, but in addition, we are now using more and more genetics to refine our diagnostics and to come to an even more precise view on our patients. So I would like to discuss if precision medicine is ready for prime time in hemato-oncology. I will briefly cover precision medicine in this talk and then discuss the relevance of genetic testing, in particular more broader genetic tests in myeloid neoplasms, AML, MDS, and MPN, and I will in particular cover clonal hematopoiesis and its clinical implications. I will then present the diagnostic workflow of a particular lab, the Munich Leukemia laboratory that has already been introduced by Dr. C. So precision medicine. We are refining the diagnosis of our patients, and genetics is one driver of this. Precision medicine, personalized medicine is very well used now in all of our universities and hospitals. The driver of this is really technology in genetics, in particular next generation sequencing, that allowed us to sequence, to analyze more and more genes in more and more patients. The idea of precision medicine or personalized medicine is to get a patient-specific target due to refined diagnostics, and then not only cover and target the disease in general, but the specific disease of a specific patient. So where are we in hemato-oncology? 2017 and this year, 2018, has been really exciting for all of us working in the field of acute myeloid leukemia. A number of new targeted drugs have been approved, and the majority of them is driven by genetic findings. Also, the diagnosis of this particular molecular aberration is necessary to have this drug delivered to the patient. So we are now facing a kind of switch of paradigm from a primarily organ-centered or morphology-centered view of cancer to a more gene-centered view. This is driven by the understanding of the underlying pathophysiology and by the application of more and more targeted drugs. So one study that is currently ongoing in Germany tries to stratify in this case, solid tumors just by the presence of targeting targetable aberrations in the genome. And we will see whether or not this direct approach of precision medicine makes it into the clinic. So what about hemato-oncology? The landscape is set. We know what are the current mutations. This is one of the hallmark studies, the third study showing all the current mutations in acute myeloid leukemia. So we know where we are standing and what we're dealing about. So we can use this information, this additional genetic information, to refine our diagnosis in acute myeloid leukemia and in hemato-oncology in general. This already has been incorporated in our classification. The WHO classification of 2001 listed 5 genetically defined entities. Now we have 31. So these entities and sub-entities of hemato-oncology are now purely defined based on their genetic aberration. So we are already seeing a transition in our classification system from solely morphology-based into a mixture of genetic and morphology. Where is this going, and where is this direct application of genetic testing in hemato-oncology? So acute myeloid leukemia, of course, still morphology is the base of what we are doing. And we can, with a short look in our microscope, tell that this patient is most likely suffering from acute myeloid leukemia with specific morphology of the blast cell. But this is not enough for today. The current WHO classification lists a number of recurrent genetic aberrations that specifically define subsets of acute myeloid leukemia. So to have your patient diagnosed according to this classification, you need to test for all these molecular aberrations. Another landmark study moved even further and more or less abolished the morphology-based classification and incorporated only genetic-based classification of acute myeloid leukemia. So on the left side, you see the genetically defined entities in the WHO classification. These are also incorporated in this classification system, but in addition, other subtypes solely defined on their genetics are incorporated here. And this really has a meaning for our patients because we can use this additional information to stratify the risk. So this slide shows the p-value, the significance of the various finding, and whether or not it is of poor prognostic relevance or of indicates a better prognosis of the patient. So we know for a large number of genetic aberrations how to deal with them in the context of acute myeloid leukemia. This nicely stratifies the survival of our patient. We can now define for our AML patients, based on their genetics, how they will perform, and therefore stratify the treatment of the patients, doing bone marrow transplantation or doing no bone marrow transplantation. So this is really what we need to refine the treatment of our patients. This has also been incorporated into classification systems. In Europe, we are primarily using the ELN classification system, the European Leukemia Net, and I just listed here in green the molecular aberrations that are defining for these disease subcategories and classification categories. So a mutation in any of those genes highlighted here in green would mean that you have an adverse prognostic classification and you will undergo stem cell transplantation in your AML treatment. But classification is not enough. We are also aiming for targeted therapy in precision medicine. We not only aim to refine the prognosis of our patient, but we also aim to give a drug that directly targets an aberration. And as already mentioned, the last years have been exciting here. We have now a number of drugs that directly target specific aberrations, in particular FLT3 and IDH1, IDH2, where specific drugs have been approved based on the genetic aberration of the patient. So to summarize this for AML, yes, genetics is definitely important and in the basic workup for the diagnosis of the patient. We use genetics to refine the diagnosis of the patient and to select the therapy, both targeted therapy and also whether or not we are going for stem cell transplantation. So what about follow-up monitoring? Once we have treated the patient, once we have luckily achieved a complete remission, is genetics still of use? So this is an old story. NPM is well established as a minimal residual disease marker in patients that are in complete remission of acute myeloid leukemia. So we do have a high number of AML patients that are positive for NPM, and we can use this NPM mutation as a very specific and sensitive diagnostic tool with qPCR to monitor the malignant clone of this particular patient. And it has been shown that the presence of MRT after induction chemotherapy is the most important predictor of long-term survival. So for NPM1, the stage is clearly set. But what about other mutations? AML is a complex disease with clonal heterogeneity. We do not see only one mutation, we do see a couple of mutations. So what mutations shall we use for follow-up monitoring? What is valid for MRD diagnostics? And this really complex game of clones. We do see that nuclear phosphine mutation, NPM1 mutation, works very well and is very well correlated to the clinical outcome of our patients. But what about other mutations? I will in detail talk about clonal hematopoiesis as a prephase of malignant hematology of myeloid neoplasms. And this prephase, this clonal hematopoiesis, is a major issue when it comes to MRD diagnostics of the patients that have achieved complete remission. Because in some patients we see that the dominant leukemic clone is eradicated by the treatment. However, a persistence of the preleukemic clone is observed. And this means persistence of genetic operations, although the patient is in complete remission. For example, DNMT3A is one of those mutations where we have a lot of discussion whether or not it is relevant to monitor this after treatment, and first studies indicated that there is no use to go for DNMT3A-based MRD monitoring. Another landmark study recently published looked beyond NPM1. So is there a clinical application for this genetic testing in the MRD setting of acute myeloid leukemia? In this cohort, samples at diagnosis of the patient and during complete remission were compared. And about 50% of the patients had persistence of mutations in complete remission. So we cannot use any mutation as a marker of residual disease. It doesn't work. If you look at this in detail, for nucleophosmin, it works nicely. At diagnosis, the mutation is present, but it's gone when the patient achieves complete remission. In contrast, for other markers, as already mentioned for DNMT3A, there is no specificity of having the mutation positive in the MRD setting. If you look at the variant allele frequency, so how much of the mutation is present, how big is the clone that is detected? You see a similar picture for DNMT3A, up to 50% variant allele fraction. That means that the complete hematopoiesis is clonal, still after achieving complete remission of the acute myeloid leukemia. So what this study did was to try to separate whether one particular mutation or a combination of mutations would be of additional value to define minimal residual disease in AML. And in particular, those three mutations, DNMT3A, TET2, and A6L1, were considered as having no value in the follow-up monitoring of acute myeloid leukemia. In contrast, for other mutations, there is some value, although persistence of the mutation does not necessarily mean persistence of the disease. When we stratify our patients according to having a mutation in those other genes, so not the three already mentioned, then we can nicely discriminate the risk of relapse when the patient is MRD positive in terms of genetics. And when we combine phenotype and genetics, so flow-based MRD diagnostics, together with genetic-based MRD diagnostics, we can even more refine this and can tell that a patient that is negative both for flow-based and gene-based MRD is very likely not to suffer from relapse. So we can use genetics also as follow-up monitoring tool in acute myeloid leukemia. So there is some value, although you have to be careful what mutation to choose and how to interpret the finding. What about other myeloid neoplasms? Myeloproliferative neoplasms, BCR-ABL negative MPN. So the clonal driver is very well established. Groups in Vienna and also other study groups have identified JAK2, MPL, and calreticulin as the main drivers of polycythemia vera, essential thrombocythemia, and primary myelofibrosis. So there we have a direct diagnostic tool that is also incorporated in the WHO classification as a diagnostic finding. This story is primarily based on JAK-STAT signaling. We have an aberrant activation of the signaling pathway, either due to a mutation in JAK2 itself or due to a mutation in an upstream receptor. In addition, also calreticulin, a chaperone protein not necessarily associated with this pathway, has been identified to be linked to it, since the mutant calreticulin activates the thrombopoietin receptor, and then again activates this JAK-STAT signaling. So we have targeted drugs to specifically affect the JAK-STAT signaling pathway, and they are used clinically for MPN patients. But what is beyond? A number of patients has additional mutations, not only JAK2, MPL, and calreticulin, but other mutations that we also find in MDS patients, in CHIP patients. These mutations primarily affect splicing factors or epigenetic modifiers. So the landscape of MPN is kind of rewritten, and it's getting more and more complicated with these additional mutations. There are two main purposes of studying these additional mutations in a diagnostic routine setup. One is, again, to redefine the prognosis of the patient. It has been shown that the presence of additional mutations, in particular in specific genes, is a predictor of worse outcome of our patients. The number of patients, the number of mutations, and the particular mutations are associated with poor outcome. So we can use genetic profiling in addition to just testing for JAK2 and CALR to refine the diagnosis of the MPN patients. In addition, there are triple negative MPN patients. A small fraction of patients is not positive for the classical driver. And here we can use next generation sequencing based diagnostics of larger gene panels to identify clonality in those patients. So according to the WHO classification, presence of another clonal marker can be used when the patient is negative for JAK2 or negative for CALR and MPL. So what we are doing is, for patients with a high likelihood of an MPN, we are doing a triple negative gene panel to test for the most prevalent mutations in this disease, and therefore to establish the diagnosis based on clonality defined by another marker. So there is use of genetics in MPN in addition to the classical pathway. MDS, Myelodysplastic Syndromes, a very heterogeneous group of diseases. The landscape is set. These are data from Munich, but also many other groups have identified the current mutations in MDS. So we do know where the mutations are, and about 90% of all MDS patients show molecular aberration. But if you look at the WHO classification, we do see nearly no mutation in this classification. The only mutation that is listed here as a diagnostic criterion for MDS is SF3B1. This mutation is linked to a specific morphology, to the MDS with ring sideroblasts, and this has been recognized due to its unique and beneficial prognostic impact on the patients. So SF3B1 is established as a diagnostic marker for MDS. But what about the others? Since 90% of the patients do have a mutation, why not using it for diagnostics? The problem here is the overlap of the mutation spectrum with MDS and clonal hematopoiesis in otherwise healthy people. And I will come to this in detail in a couple of minutes. There's a large overlap in this mutation spectrum, and in particular mutations like DNMT3A and TET2 do not discriminate between MDS and clonal hematopoiesis in healthy people. And therefore the WHO recognized that the specificity of these mutations is not high enough to use them as a diagnostic criterion for MDS, and therefore we do not see any incorporation of these findings in our current diagnostic workup. Still, there is use for them. So prognostic classification in MDS is still based mainly on morphology and cytogenetics. This is the revised IPSS, so the International Prognostic Scoring System for MDS, based on the subtype, on the presence of blasts and the number of blasts and the presence of cytopenia. In addition, specific genetic operations, here cytogenetic operations, are incorporated to stratify the prognosis of the patient. Molecular genetics, in terms of next-generation sequencing panels, is useful to further refine the diagnostic workup in terms of prognosis and prognostication of MDS patients. So a number of groups have established the impact of additional mutations and in the prognosis of MDS. They can either refine the IPSSR or even replace the IPSSR. Another group from Spanish colleagues addressed this finding and came up with a rather easy prognostic scoring, SF3B1 as the only beneficial mutation and a number of mutations that are associated with a worse outcome. These mutations, in particular A6L1, are now incorporated into molecular added versions of the IPSSR. We do see a number of those refined scoring systems now being published and validated within our study groups. So to summarize this for MDS and MPN, yes, there is some impact to make a diagnosis of the disease, but it's limited. Only specific operations and specific situations are in need to perform larger gene panels to establish the diagnosis of an MPN or an MDS. For prognosis, there is further evidence that we can go with these mutations and further refine the prognostication of the patients. For follow-up monitoring, there's currently only little evidence. Only after stem cell transplantation, there are data for our MDS out that the application of additional genetic profiling is usable in the clinics. So I already referred several times to clonal hematopoiesis in otherwise healthy people. This is a very interesting phenomenon that will have a broad impact on not only hematology, but medicine in general. So the idea is that during aging, we acquire somatic mutations in our hematopoietic stem cells, and these have a clonal advantage in their proliferation and give rise to the clonal expansion of a mutant hematopoietic stem cell and therefore clonal hematopoiesis that can be detected in peripheral blood. So these cells look perfectly normal. We do not see any kind of dysplasia there. We do not see any kind of blood count abnormalities. Still, there's a mutation, and we can detect this mutation and this aberration using genetics. So this is, of course, a prephase of cancer, of hematopoietic neoplasms. The acquisition of additional mutations alters the phenotype, and we get a more aggressive phenotype, we get leukemia. What is astonishing is that this phenomenon is very frequent. Of course, we do see an acquisition of such clones during age, but it's far more prevalent than we would have thought. The first landmark studies showing this in large patient cohorts have been published just 3 years ago. So the prevalence of somatic mutations, clonal hematopoiesis in large patient cohorts. And the number is impressive. So in elderly patients, patient is not the correct term, in elderly healthy individuals, we do see up to 20% having clonal hematopoiesis being only detected by a next generation sequencing test. So normal blood counts, but aberrant genetics. And again, this mutation profile is rather similar to what we see in Myelodysplastic syndrome. There's been a lot of discussion how to name this, and is it a disease, a prephase of a neoplasm, how to communicate with the patient? Because you cannot tell the patient you have a kind of preleukemia. He will freak out. There's no evidence that it is really an important finding in these terms. What is currently the most used term is clonal hematopoiesis of indeterminate potential, or CHIP. And this CHIP has been defined as the presence of such mutations without any morphologic evidence of a hematopoietic neoplasm. And this brings us back to the relevance of morphology. We need morphology to discriminate CHIP from MDS and other types of myeloid neoplasms. So what's the clinical impact of this clonal hematopoiesis? Already the first study indicated that there is an impaired overall survival in the population. So healthy elderly individuals are of increased risk to die when the hematopoiesis is clonal. And this cannot only be explained by the risk of progression to leukemia. So of course, progression to leukemia is an issue, and I will briefly cover this, but is not what affects the overall survival of the population. But let's start with this first. Can we assess the risk of progression in these patients? So CHIP is now well recognized as a prephase of myeloid neoplasms, a prephase of MDS, and a prephase of acute myeloid leukemia. So the patient acquires a mutation that gives rise to the expansion of a CHIP clone. This clone acquires additional mutations, becomes more and more aggressive, and then we have the overt disease. We had a study group in Vienna to discuss how to term those types of prephases and shadowlands in the shadowland of MDS to establish terms both for scientific purpose, but also for communication with the patient. And there is a term of idiopathic cytopenia of undetermined significance, meaning the patient has cytopenia, has refractory anemia, for example. We do not find the reason for it, but we exclude MDS. So there's no overt dysplasia. We cannot make the diagnosis of an MDS. Still, the patient has unexplained cytopenia. So those patients are determined to have ICAS, idiopathic cytopenia of undetermined significance. The combination of CHIP, so a clonal marker, and ICAS is then termed clonal cytopenia of undetermined significance. So it gets complicated with all those terms. Nevertheless, this means that we can use genetics to stratify the prephases of MDS and myeloid neoplasms and to stratify the risk of the patients for progression. So the idea would be to use genetics to tell the patient whether or not he has a kind of high-risk CHIP, and he really needs to care for his leukemic progression risk, or he's in low risk and long-term follow-up is sufficient. This is one interesting study in this field from colleagues in Italy that sequenced a large number of patients referred to them with cytopenia. And the number of them shown here in green had this kind of unexplained cytopenia. And the number of those patients had mutations in various genes. You're not supposed to read all those genes. Just each lane here represents such a patient, and the green spots indicates the presence of a mutation. The important thing is when you stratify the outcome of those patients. So of those patients with unexplained cytopenia, about a third had additional clonal markers, so clonal cytopenia of unexplained origin. So the risk of progression was very low for those 2/3 of patients that did not have a clonal marker. In contrast, having one or more mutations was associated with a high risk of progression to MDS, AML, or any other kind of myeloid neoplasm. So here are the survival plots for probability of evolution to a myeloid neoplasm with having no mutation or having any mutation. We can even further refine this by stratifying the patients in having more than one mutation or having particular high-risk mutations. Those patients are really at a high risk to develop an myeloid neoplasm within the next 1 or 2 years. So this is very relevant for clinical practice. When we had this study group meeting 2 years ago, there was discussion whether or not we would see those patients actually. But now we see them because they are sequenced for example, a solid tumor and germline is sequenced in addition, and we do find those patients more and more frequent. and they need to deal with them. Another study, very recently published, used this information to kind of predict the risk of acute myeloid leukemia. Again, we had patients with a pre-phase of acute myeloid leukemia, where clonal hematopoiesis was already established, so pre-AML chip, compared to controls that also had chip, but did not develop AML. And yes, there were some differences. So the number of mutations was different, the clone size was different, and the mutation pattern was different between the pre-AML chip and the low-risk chip. And the study group used then particular patterns of mutations to predict the risk of progression to AML as a kind of screening marker. So specificity and sensitivity of this type of analysis is not high enough to go for AML screening, but nevertheless, the idea is interesting to use genetic profiles to further refine the risk of our patients. And very astonishing finding is this. The impaired overall survival is not explained by the risk of progression to acute myeloid leukemia, or the MDS, because in absolute numbers, this is still only a small fraction of patients. This is what most likely drives the impaired overall survival. There's a clear association of CHIP, presence of clonal hematopoiesis, with cardiovascular disease and cardiovascular death. So also in the first study that described this finding, there was an association observed between presence of CHIP and coronary heart disease and ischemic stroke and death due to these reasons. There's been a lot of discussion whether or not the study was properly controlled, if there could be an underlying bias, smoking, for example, to cause this, and the study population was not powered for this type of analysis. Recently, the group of Ben Ebert published a follow-up publication specifically powered for this question, whether or not CHIP is a risk factor for cardiovascular disease. And this is the main outcome. It is a major risk factor. So when stratifying for all those classical risk factors of cardiovascular disease, cholesterol levels, smoking, diabetes, and so on, presence of clonal hematopoiesis was the second highest ranked predictor in the multivariate analysis. Only overt diabetes was more important to predict cardiovascular death and cardiovascular disease. So the odds ratio for having coronary heart disease was nearly 2 when you're positive for CHIP. Even more impressive numbers for early onset myocardial infarction. 4 times higher risk when you have clonal hematopoiesis. So we will see in the next couple of years whether or not we can use this information to stratify not only patients referred to the hematologist, but referred to the cardiologist. And then, for example, start earlier or more aggressive with optimizing the risk factors of our patients. Interestingly, this is not only an association, it's also causative. Mouse models have been used to demonstrate a direct link of clonal hematopoiesis to cardiovascular risk, in particular to the propagation of atherosclerosis. So if you use a TET2 knockout in myeloid cells in the mouse, so meaning you kind of model clonal hematopoiesis, TET2 is one of the current mutations in CHIP, then you're doing atherosclerosis model in the mice with an LDL receptor knockout mouse. And what you observe is an increased atherosclerosis, increased plaque size in this mice. So CHIP directly drives the propagation and establishing of atherosclerosis. How do we currently think this comes to happen? The clonal hematopoiesis gives also rise to clonal monocytes and macrophages that harbor these types of mutations, and these are prone to be pro-inflammatory. In particular, secretion of various cytokines like IL-1 beta has been demonstrated to drive here a pro-inflammatory state in the blood and directly propagates atherosclerosis and therefore leads to cardiovascular disease and death. So prephases of hematologic neoplasms are directly associated to myocardial infarction, an astonishing finding. And we will see in the next couple of years patients referred to us, to the hematologist, based on cardiovascular risk assessment using genetics. So to summarize this part on clonal hematopoiesis is far more frequent than we would have assumed. Up to 20% of the elderly patients are positive, are having a clone in the hematopoietic system that can only be detected by next-generation sequencing. And those patients have two major conditions. One is increased risk for cardiovascular complications and disease. The other one is an increased risk for development of myeloid neoplasms. So both clinically very relevant endpoints. In the last couple of minutes, I would like to present you a workflow and how to incorporate this type of analysis and this type of knowledge into the workup of our patient. And I will here refer to the workflow at the Munich Leukemia Laboratory, one of the most renowned reference laboratories in Europe, where I have had the chance to work for 8 months. The team of Thorsten Haferlach, and in total a team of 200 people only working on the diagnosis of leukemia. So a number of different techniques from morphology to cytogenetics to molecular genetics is implied, and more bioinformatics and artificial intelligence is used to get a meaning out of this enormous amount of data that we are generating here. Still, the workup is driven by morphology and by immunophenotyping. We do have very early and very fast the information of these techniques. We know how to stratify and how to go further in genetic testing based on morphology. Still, typically it is not the only tool we are using. This is just a circus plot showing how all these techniques are interacting. So in the majority of patients, we're using a couple of techniques to get to the diagnosis of the patient. And one of the interesting findings here is we really optimize the turnaround time of next-generation sequencing. Of course, flow and morphology is much faster, and this is where we are heading first. But when it comes to genetics, next-generation sequencing is now as fast as cytogenetics, even faster in many cases. So when the karyotype comes back, also the NGS panel comes back. So we can really use this information in a timely manner and incorporate it into the treatment and the management of our patients. So of course, conventional cytogenetics, conventional genetics is still of use. However, we do see here a fast progress into next-generation sequencing that replaces some of those tests. So next-generation sequencing, I will not cover this in detail from a technical point of view, but it's still a rather time-demanding and complex process, lasting at least a couple of days and acquiring a lot of bioinformatics to get any meaning out of those data. Still, this workflow is well established and can be used for clinical application in a large scale. So this is the gene panel that is typically used for both myeloid and lymphoid neoplasms. 63 genes, about 35 of them are currently mutated in myeloid neoplasms, and this gene panel is analyzed for every patient that undergoes genetic testing, with a turnaround time of about 1 week. So here are impressive numbers of genes that have been analyzed during the last couple of years. So we are really talking about a couple of thousand patients that have been analyzed for all those mutations. In total, about 40,000 patients undergoing the complete gene panel. And in line with literature, we do see the recurrent mutations being often mutated in our patients. Still, a number of patients does not show any mutation, although there is a suspected hematologic neoplasm, and this information is also of high clinical value. Then you can rule out clonal hematopoiesis. So this is the status quo. We are using next-generation sequencing, incorporated this in our diagnostic workflow together with other techniques. what is a possible outline for the future. So in solid oncology and in hemato-oncology, we are currently relying on targeted sequencing of smaller gene panels. We are using whole exome sequencing for a number of cases, in particular for discovery of potentially targetable mutations. We do not use regularly whole genome sequencing, but the field is moving. We see an application of more and more larger gene panels. We see more exome sequencing, and some groups are trying to establish whole genome sequencing, including the Munich Leukemia laboratory. This is driven by, again, technology. Sequencing costs are dramatically dropping. The $1,000 genome is reached. So we can think about incorporating this as a diagnostic tool also for the clinical setup. And this is one major project headed by Thorsten Havelach and Manja Meggendorfer at the Munich Leukemia laboratory, sequencing the whole genome and the whole transcriptome of 5,000 patients with myeloid neoplasms. So the conventional sequencing workflow is now replaced with the new NovaSeq platform of Illumina, really large machines with a high throughput, and just a number, the amount of sequencing data that is acquired is about 1,000 times higher for one patient with this new type of analysis. So this is how it looks like, a huge facility of NovaSeqs. So at least in Europe, still the largest one that is available. One of those machines has a list price of $1 million. So really a large project to go for. What does it mean, exome sequencing, genome sequencing? So what I've been talking about up to now was detection of small gene panels, 60 genes, 100 genes, whatever. Exome sequencing means sequencing of all coding genes, so more than 20,000 genes. Still, it is only a very small proportion of the whole genome, about 1% of the genome. Whole genome sequencing is really another scale of data that we are dealing with. But whole genome sequencing would in theory give additional layer of information. We can, with whole genome sequencing, both cover mutations in non-coding regions that are more and more recognized to be of relevance in the pathogenesis of disease. And we can cover structural aberrations, copy number variations that we miss with those small gene panels. So what does this mean? Small gene panels are very useful to detect aberrations that just change one amino acid, one base of the gene, or to detect small insertion of deletions of several bases. However, they fail to detect large structural arrangements. So what we are typically using for cytogenetics. So we would not detect a 5q deletion with those small gene panels. In contrast, whole genome sequencing covers both at the same time. So from those data, you can interfere both large structural rearrangements, but also the very small and specific mutations. And this is real life data from those kind of sequencing. The copy number variation on the whole genome for the individual chromosomes. And just to a magnification of this, chromosome number 5 with a 5q deletion, chromosome number 7 with a 7q deletion. So this type of analysis is useful to more or less replace cytogenetics and to have one shot for genetics and cover all. Also, structural variations, in this case, translocations, are nicely picked up with this type of analysis. So what we do see here, to summarize, is we do see a change in our diagnostic field. Up to now, we used a large variety of techniques to study both the phenotype and the genotype of the patients. In the next couple of years, we will see a shift. This has already begun, and this will move forward. That next generation sequencing more or less replaces other genetic techniques and becomes more prominent in the diagnostic workup of hematologic neoplasms. Still, there is no change in the phenotype. We do need the phenotype, morphology, and flow in addition to define the diagnosis of our patients, because otherwise we cannot discriminate between just clonal hematopoiesis and, in a word, hematologic neoplasm. So still, we need to integrate both the genotype and the phenotype of our patients. So to summarize, I hope that I could convince you that genetic biomarkers are important in the diagnostic workup, both for diagnosis, prognostication, and also for follow-up monitoring of patients with myeloid neoplasm. Clonal hematopoiesis is a very interesting finding. We are excited about this, and it is both a frequent prephase of myeloid neoplasms, and it is also a major risk factor for cardiovascular disease. And next-generation sequencing-based testing has become an integrated part in the diagnostic workup of our patients, and we will see a shift towards more NGS in the near future. With this, I would like to close with a view of my new place, the Tyrolian Alps, the view down from the mountain to the city of Innsbruck. Thank you very much for being here. It was a great pleasure. Thank you very much for the invitation. Yes. Yes, this is of high relevance, and this 5,000 genome project that we are dealing with covers both sequencing of the genome and sequencing of the transcriptome. So gene expression analysis is incorporated into this, and these two layers of information on the gene level will both be needed. Totally agree. Yeah. I think that we will see a trend. It will not replace morphology completely, but it will refine this. For example, AML and MDS, the discrimination with 20% blasts is kind of arbitrary. And if we do see a high-risk MDS with 10% blasts and an IDH1 mutation, it's very likely that we should go for the same IDH1 targeting drug that we use for AML. But future studies are needed to really tell us if this idea is correct. Yeah. 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 Yeah.
How are you?
Yeah. Currently, we are able to keep up. So in Germany and Austria, this is not so much the case or the problem of the individual patient. So the federal insurance covers this for every patient, but it will become and is becoming an issue for the health insurance system in total, of course, because of this high amount of money they spend for this. I do not have the solution to this, but I think that prices will begin to drop also for the medication if it is used for a broader range of patients. This might be an issue. We have to negotiate with the pharmaceutical companies on the prices on a large scale, governmentally. And the other thing is, especially because those drugs are so expensive, we need to know for the individual patient whether or not they will work. It doesn't make any sense to use very expensive drugs that have no chance to work. Therefore, we need this kind of precision medicine to really tell upfront from a genetic test that is not cheap, but still rather cheap compared to the drug, whether or not the drug will work. So this kind of companion diagnostics will catch up and is already there. None. Yep. This center that I've presented is the Munich Leukemia Laboratory in southern Germany. And this covers basically the majority of all samples in Germany. And there's none center comparable to this in Austria. Yes.
Baseball bat to our speaker.